Hello and welcome back to our IVF webinar. This time I am back. I am your host, Caroline, as always, and I am glad that we are having another top expert. And this time, and actually, this is her this is her second time with us tonight. We are having Dr. Clara Colome from Eugene Clinic located in Barcelona. Hi, Dr. Clara. How are you feeling?
Hi, good evening, Caroline. Good to be back.
I
Feeling
am
great.
Excellent. I am really happy that you have joined us once more and will present another very interesting and indeed very also difficult topic, which is genetic screening and art and gamete donation. And before we start, as always, I want to thank to our ambassadors and partners for um, joining us, for being our ambassadors and partners, and for their support. As you know, without them, it would be very hard to handle so many of those events that we already had. And of course, there are some more coming up. So thanks to them for their support. And as I've mentioned already, we will now go with the presentation. So just to let you know, Dr. Clara will start off with the presentation that will take approximately 30 minutes, and then it will be time for your questions. So as always, don't forget to type in all the questions in the chat section so that she can answer them for you. Don't miss out on your chance to ask your questions. And I guess that is it from me. Dr. Clara, are you ready to begin with the presentation?
Okay, thank you very much for the presentation, Caroline. And again, thank you very much for letting me be here this evening. And today we will discuss about genetic testing in ART and expanded carrier screening in ART and gamete donation. As Caroline said, I come from the Eugene Clinic in Barcelona. There are different clinics all over the world, but today I'm speaking from Barcelona. So first of all, what is an expanded carrier screening test? Well, it should be a test that has been done preconceptionally. So it's a genetic test for individuals that are at no risk or without family history for recessive inherited disorders. Its aim is to identify healthy carriers of autosomal recessive or X-linked recessive inherited diseases. We'll get deeper on that later. And basically, the objective is to assess the risk of having a child with a severe recessive disease. So I do not know if you remember your biology lessons, but all humans, we have 46 chromosomes. 23 come from our mother and 23 come from our father. And if we have an affected copy of mutation, but the other one, the one coming from your father, for example, is normal, then you might be a healthy carrier for a genetic autosomal recessive disease. That means that you can be a healthy carrier for this disease, and you won't probably find out about that unless your partner also carries the same disease. And then when you have children together, you would have 25% chances of having a child with the particular disease because he or she would inherit the affected gene from his father and the one from his mother. We have another type of recessive diseases, which are the X-linked recessive diseases. As I'm sure you are all well aware, women, we have 2 X chromosomes, and men have 1 X chromosome and 1 Y chromosome. That means that recessive diseases that are linked to the X chromosome, for female, we can be healthy carriers of those diseases. Men cannot because they only have 1 copy of the chromosome. So if it has a mutation, they will develop the disease. That means that if a healthy carrier for an X-linked recessive diseases has a child, 50% of her male children will have the disease and the other 50% will be healthy. And all baby girls will be healthy, though half of them will carry the mutation as well. So this is quite complicated, but basically it translates into the fact that over 10,000 diseases have a Mendelian inheritance, which is what I just explained to you. 1,400 of them are recessive inherited diseases that are transmitted autosomically or X-linked. Basically, when we take a look at the population, we see that over 50% of the population could be a healthy carrier for one of those diseases. And 3 to 4% couples are at increased risk of having a child with one of those diseases. So if we take a look at the data, it's quite important. In fact, 3 to 5% of all births result in congenital malformations, which means 8 million children every year are born with a serious defect of partial or total genetic origin that could be linked to a recessive mutation. 20 to 30% of all infant deaths in the world are due to a genetic disease, and it leads to 18% of pediatric hospitalizations. In fact, the percentage of non-consanguineous couples carrying the same disease is between 2 to 3% in different series. So it's, when we take a look at the general population, it's quite a lot of people. When we take a look deeper to the incidence of genetic diseases, there are 10 genetic diseases per 1,000 newborns. Of those, 7 will be dominant diseases, which means that if we have one copy of the gene, you will develop the disease. But 3 of them will be recessive, and those are the ones that we can avoid, we could potentially avoid with expanded carrier screening tests. So who should do this kind of genetic testing, or who is at risk of having a child with a genetic disorder? Well, all of us. We can be healthy carriers for the disease and decide to have a child with our partner, but even when we use gamete donors, even though they are healthy, even though we do many tests on them, they could also carry a genetic disease. So if you don't look for it, we might eventually find ourselves with a child with a genetic disorder. We can think that many patients actually think that, okay, I do not have a family history of any disease, so why should I be tested? In my family, no one has been sick. But recessive diseases can hide quite well. For example, here we have this genetic family tree where this black square would be the affected family member. This was 7 generations ago. And we have this couple here. One carries 1 mutation. She's healthy, perfectly healthy. But when she will have a child with a male partner who also happens to have the same mutation, they will eventually have a child with this disease. So if it's depending on the prevalence of the carrier status, this can remain unnoticed for many generations. In fact, 80% of couples with a child affected of one recessive disease, they didn't have any relevant family history. If, as we saw before, this was 7 generations ago, at that time, most people do not even remember or know where their grandparents were born. So imagine to remember 7 generations ago, there was this disease in the family. And 95% of children with a hearing loss detected by universal screening that is performed at birth have both parents with a normal hearing and without a known family history of deafness. So you can see it's quite relevant. In fact, regardless of family history, all humans are carriers of pathogenic variants in genes associated with genetic diseases with autosomal recessive or X-linked inheritance patterns. And each one of us carries 2 to 8 severe recessive mutations and dozens of private variants of a known effect, regardless of our ethnic origin. So no one is, let's say, safe of being a healthy carrier for one disease or another. So how should we perform a carrier screening test? Well, it should be offered before pregnancy, preconceptionally, because it allows us more reproductive options. And because knowing your reproductive risk, you can consider alternative reproductive options or solutions. And it also allows us to have less emotional distress than if the tests were performed during pregnancy. And at that point, you have to make a decision regarding the results of these tests. Imagine when you're pregnant already, this is a future child that already exists. Then if you find out that he's affected of a genetic disease, it implies a very severe and difficult distress, emotion especially, to decide whether it is possible or not to continue with his pregnancy. And we're discussing a lot lately about expanded carrier screening tests, but is this a new concept? Well, not really. A screening based on prevalence of the diseases and geographic or ethnic criteria has been performed for a while already. In Greek Cyprus, they test for beta thalassemia, which is a kind of genetic anemia, since 1973. In New York, there was a group of Orthodox Jews, Ashkenazi Jews, that started testing themselves for Tay-Sachs disease since 1983. And now it's been extended to all Ashkenazi Jews in the world, and they test for over 16 diseases because, as you probably know, Orthodox Jews tend not to mix with other ethnic origins, and they are at high risk of some recessive diseases. Also in the USA, they offer screening for cystic fibrosis since 2005, and in Israel, they test for all disorders that have a carrier rate in the general population equal or superior to 1 in 60, or that affects 1 in 15,000 live births. They offer it for the entire population of the country since 2013. So for specific ethnic groups, this has been going on for a while now. The objective would be to change the approach, not to test a determined number of severe diseases in a especially risk group, like for ethnicity or for family history, but to do a universal screening of hundreds of diseases of variable severity. So how would we perform these tests? Well, usually this kind of tests need clearly a sample, a blood sample, or maybe a saliva sample. It can also be done on saliva. And the best strategy would be to test both partners at the same time. That's what we usually do in our center. We do the blood test and then or the saliva test, and then we do the test for both partners at the same time. It is true that to limit costs, initially, we can perform the sample for both patients, but just analyze once, usually the female partner one, because it's where we can also detect X-linked recessive disorders. And then the partner sample remains in custody for up to 3 months, and it's only analyzed if the female partner is a carrier. Okay, because if the female partner is not a carrier for any of the diseases that can be tested, eventually the couple can decide that they take this chance. But even if we test both partners or the donors, it is true that 0% risk does not exist, because every technique, every genetic technique that we can apply nowadays has a residual risk, even prenatal screening testing during pregnancy. And there is a risk of having an affected child even after the carrier screening has a negative result. The objective would be to have an incredible risk reduction with this kind of testing. But unfortunately, in medicine, 0 risk is not possible. So then again, if we have a couple where both partners carry the same genetic mutation for a recessive disorder, what would be the reproductive options that they have? Well, we could go through an IVF with a PGT-M, with a genetic testing of the embryos before implantation, looking for this particular disease, and just transfer embryos that are not affected with the disease. They could carry the disease as the parents, but not develop the disease. We could decide to conceive naturally or with an assisted reproductive treatment, and then perform afterwards a prenatal diagnostic during pregnancy in case the pregnancy occurs. For me, this is not the ideal option, especially if we have to go for an assisted reproductive treatment, because again, the later you know, the more stressful the situation becomes. We could eventually go for a donated gamete and go for an IUI or an IVF with donor sperm if the female partner is the one who has if the male partner is the one who carries the mutation and the female wants to conserve her oocytes, or the other way around, depending on the situation. Eventually, adoption should also be considered as an option. Of course, refraining from having children is always a possibility that the couple has to evaluate. And clearly, change partner, well, it's not usually the most common option, but if you're looking for an excuse to change your partner, this clearly would be a good one. As you can see, these are not easy solutions, so it is good to know the sooner the better. So, what kind of tests could we do? I mean, there are many labs in the world that offer genetic screening tests. There are some that test for more or fewer mutations. So which would be the good one? Well, is there a consensus on what diseases should we test for? Well, let's take a look at the guidelines. The American Reproductive Society, the Spanish Fertility Society in the United Kingdom, they usually advise all couples to perform a karyotype, which is a basic genetic test that shows us the number and shape of chromosomes. And they also advise you to test for cystic fibrosis. Cystic fibrosis is a genetic disease that affects basically the lungs, and it's quite common, especially in Europe. Then we have the American College of Medical Genetics, that advises to test for spinal muscular atrophy, and the American Society and the Spanish Society advise to test for X-fragile syndrome, which is an X-linked recessive disease that causes mental retardation in male children. And the Obstetrical College in the UK advise also to test for genetic anemia in African ethnicity. We also have to take a look. We have to take a look at the guidelines. We have to take a look at the legislation in each situation. We have here in Spain, we have the European Directive on Tissue and Cells from 2006. We have the Spanish Reproductive Law from 2000. The last update was in 2014. And we have the ESHRE Task Force on Ethics and Law position paper, which is the European Reproductive Society, that on genetic screening for autosomal recessive genes, according to international scientific evidence, they advise to test depending on the ethnic background and the family history after consent is obtained. So regarding donation, they advise to test depending on the ethnic background and the family history. But then again, we just saw that ethnic background is not always a good thing, because we do not necessarily know our ethnic background, especially in countries like ours, where people historically have come from many different places. And if you remember, family history was not always a good option. So when we're discussing, especially when we use donor eggs or donor sperm, the objective is not the test by itself, but the matching, to compare the genetic results of the two individuals involved in order to evaluate the reproductive risk that they have, in order to avoid clearly having a child with a genetic disorder, but also not to reject healthy carrier gamete donors, because again, if you remember, we said that over 50% of the population carries a recessive inherited disorder. And that doesn't mean that they are not healthy and they should refrain from having children. So the matching between the donor and the recipient or the partner, that is the main goal of this type of testing. so that we have a carrier partner or a carrier donor and a not carrier donor or not carrier partner. This would allow us to have a healthy child that could carry or not the disease, but it will be a healthy person as his or her parents. Then again, there's this American College of Medical Genetics statement that says, so regarding what kind of diseases and when we have to test, what kind of diseases should we look for, which are the diseases that should be included in these panels? Well, there should be diseases that are severe enough that if both partners were a carrier, we would perform a genetic screening test during pregnancy. There should be diseases of which we know the mutation that causes them, and when we are able to assess the residual risk that will remain. And also, there have to be diseases where the association between the mutation and the symptoms is clear enough in order to be stated. So, regarding oocyte donors, there's this new guideline from the Spanish Fertility Society, the group that analyzes donation, gamete donation in Spain. In 2019, last quarter of 2019, they issued this guideline advising on basic genetic study in gamete donors, and they advise to perform a karyotype. They advise us to test for cystic fibrosis, for spinal muscular atrophy, for genetic deafness, for genetic anemia, and for X-fragile syndrome. These are the diseases that they advise to study in all gamete donors. So that's what we do, and if donor carries one of these diseases, we have to take it into account. But then again, even if we do this test, of course, there's this discussion of, is this necessary? Do we need to do this screening test? Well, clearly, we have to avoid these kind of headlines, baby born with cystic fibrosis after IVF botched screening. Again, risk zero doesn't exist, but knowing that we can perform an expanded carrier screening beforehand, it is true that eventually we should avoid this from happening. And to end with the debate, well, is there a moral obligation to conceive children under the best possible conditions? In my opinion, expanded carrier screenings offers the greatest benefit if it's performed preconceptionally, because it allows the patients, the clinicians, to assess well the situation, to know and assess the risks, and to discuss clearly and freely the options without the pressure of already having a pregnancy developing. So maybe we can have more of this discussion afterwards. I hope the information was clear. Thank you for your attention. And now, if there are doubts or concerns regarding this topic or anything else you think I could help you with, I would be glad to try to answer your questions.
Excellent. Again, thank you so much for a very interesting and thorough presentation, as always, actually. And thank you for explaining this topic to us. And yes, now it will be time for your questions. So again, I can only encourage you, if you have any doubts or have any questions in regards to this topic, just go ahead and type those questions in the chat section so that Dr. Clara can help you out as much as possible. And someone is typing, so of course I just want to make sure that we have the first question and we will be able to go ahead with this. So let's give it a minute and let me show you. The very first question has just shown right here. Okay, so hi doctor, is it possible to find mutations in eggs or sperm, or we must wait until the embryo is formed?
Hi Adrian, this is a very good question. In fact, no, it is not really possible to find a mutation in eggs or sperm. We can analyze some things of eggs and sperms, but a mutation, we have to find it in a genetic sample in blood or saliva before obtaining the gametes, or once the embryo is already created. But we cannot analyze the mutations in eggs or sperm. No, it is not possible yet.
Okay, thank you so much for answering the very first question and for your question. And again, there is someone else typing, so we need to wait a bit and for that question. So let's wait a bit then, yeah, so we can have that.
Sure.
Yep, we need a bit longer minute, but that's okay.
So I don't know, in the meantime, I'll just explain to you
Yeah.
maybe that in our center, what we usually do is we advise to do an expanded carrier screening test to all of our patients. When we use our oocyte donor program, we always do the genetic matching between donors and recipients. And when the couple is using their own gametes, we always advise them at this point, and for a few years already now, to do this expanded carrier test. And we feel very comfortable with it, and also patients.
Mm-hmm. Okay, because that gives you that like confidence, yes, and also reassurance that everything has been checked and you are definitely more comfortable with it, I
Exactly,
would say. Yeah.
exactly,
Mm-hmm.
exactly.
Thank you so much for adding this. Of course, this is definitely something to remember, indeed. And we are still waiting. I guess that will be like a longer question for
Yes, I
someone
can see
maybe,
that.
or someone. There are a few people just typing those questions, so
Good.
might be. We just need to wait. Okay. Yes, there is another one. Let's have a look at this. Okay, and so what are the genetic tests that you advise to do before going to the IVF process between a female patient and a sperm donor? I think the doctor, yeah, it's true. You kind of answered that as well, but
Yes, well,
anything you can add?
thanks for the question, Carolina. We usually advise when we are, depending on the situation, we might advise to do a karyotype, a basic karyotype for the female patient. Clearly, we always do a karyotype for the sperm donor, which is this basic genetic testing. And then we advise to do the expanded carrier screening test. And then again, the important thing is not the result of the test, but the matching with the best possible donor genetically.
Mm-hmm. Okay. Okay. Thank you so much once again for answering this again and well, for your question indeed. And again, we just need to wait a bit for another question. As you can see, again, someone is typing.
Mhm.
So we just need to be patient and have another question. Yes, okay, let's have a look. There is another question ready as well. So can a double biopsy be done on the blastocyst just in case of for a false negative result to avoid damaging the embryo having to be defrosted and done again as a backup?
This is a very interesting question. Thank you, Angela. Well, here we're talking about slightly different situations, which is when we do a PGT, a genetic pre-implantation test of the embryo. As you are well aware, we do the biopsy of the embryo on blastocyst stage. And we usually perform the biopsy. We remove part of this blastocyst tissue, and then we vitrify, we freeze these blastocysts, waiting for the results. And not necessarily a false negative. It's just that sometimes the result is not conclusive enough, and we have to repeat the biopsy. And therefore, exactly what you were saying, we have to defrost the embryo and then freeze it again. But well, technically, we could do a double biopsy, but a biopsy of an embryo is quite delicate. It's an embryo is a future being that is not very big. So we have to minimize the amount of tissue that we remove from the embryo. So even though technically it shouldn't be impossible to do the double biopsy, we would never do it, because most likely we will definitely have a result with the first biopsy. And we would risk damaging the embryo too much, doing it twice at the same time if it's not necessary. Hope I have helped you with that, Angela.
All right, excellent. Thank you so much for your question, indeed, as well as your assistance with that as well. And sorry, I just need to check. Yes, there is another question. So, are mutations related to age? As donors are under 35, is it more secure to go through egg donation treatment than own eggs for a 40-plus patient?
Well, this is a very interesting question, Adrian. In fact, yes, the answer would be yes and no, and I'll develop. Some mutations are related to age, especially in females. As you all know, we have a determined number of eggs since our birth, and then we use them until they're over. Men, on the other hand, they continue producing sperm until they die, basically. So the older we get, the fewer eggs that we have, but also the more mutations these eggs might carry. So over 35, but especially over 40, the percentage of eggs that carry mutation is high. But these are mutations linked to the number and shape of chromosomes. That's why, as age advances, we are at a higher risk of a miscarriage and at a higher risk of having a child with Down syndrome, which means that your child has 3 copies of the 21st chromosome. This is, however, not linked to the expanded carrier screening test because these Mendelian inherited genetic diseases are not linked to the age of the patient. If you have a mutation, you have it since your birth. So it is more secure to go through an egg donation treatment than with your own eggs for a 40-plus patient regarding malformations and regarding Down syndrome and miscarriages, but not regarding diseases such as cystic fibrosis or muscular atrophy, for example. Hope this was helpful.
Thank you so much for your question and again for your answer to this. And there's another question from Adrian. So let me show you this. The genetic tests are always included in the treatment?
Well, we do not force the patients to do it. We always like talking to our patients and decide together which is their best option, but it's definitely always advised to be performed and almost always done. If you are asking if it's included in the cost of the treatment, it depends, but usually not. It has a cost because genetic analysis it has to be performed.
Okay. Thank you for clarification, of course, as well for this. Okay, next question. It's quite a longer one, okay, 2 parts of that. So, potential donor is autosomal recessive carrier of 2 genetic conditions. That you can see the conditions. I'm not going.
Yes, don't worry, don't try to read it, Caroline.
Thank you. And so the question is, I will go back to this one. How serious would these 2 diseases be if babies are born with this? My husband does not have these carrier conditions.
Okay, so here we have a potential donor that would carry a GJB2 mutation, which is linked to the genetic deafness. There's actually a quite frequent disease that causes a hearing loss, usually sometimes progressive, sometimes from birth, which is not related to any other malformation or alteration, and it's genetic. It's the most common cause of deafness in the world genetically, and this is what this potential donor would carry. And then it carries a metabolic disease mutation, which is phenylalanine hydroxylase deficiency. Well, these 2 diseases are not life-threatening, but clearly in this case, again, you have this information of a person who carries 2 mutations. This is not what interests us. What interests us is if the partner carries or not these mutations. Then again, you were telling me, Angela, that the partner does not carry these mutations. So usually what we do is we pass these results with a genetic specialist that assesses the remaining risk. So even if your partner is negative and the donor is positive, there is still a risk that the child could be born with one of those diseases. But the risk is usually really, really low. It depends on the type of test that you performed, because there are tests that are more thorough looking at the gene than others. So I cannot really answer you to 100% with the information that I have, but I think you could go ahead with the protocol without much issue. But then again, what we usually do in our center is we discuss with the patients after a genetic expert consultation about the risks that remain in order to make the best decision.
All right, excellent. Thank you so much for that clarification. Okay, and there's a follow-up here also.
Okay.
Genetic cancer said 1 in 19,000 and 1 in 20,000.
So that means that if you had 20,000 children, one would be born with this disease. I think this is a risk that you should be able to assume. Of course, each person is different. What we usually, for example, when we think about Down syndrome, when we are pregnant and we do the first trimester screening test, which is done in blood and with the ultrasound assessment, they advise to perform an invasive test, such as amniocentesis, when the risk is superior to 1 in 250. So if you compare those data, you can see that 1 in 20,000 is really very, very low. So in our center with this risk, we would go ahead with the procedure. But then again, the risk is never zero.
Okay, so we all need to remember that as well, yes? And that is never like 100% guarantee when it comes to
no, but you know,
genetics.
being a mother or a father, nothing is 100% sure and guarantee. This is something that you have to learn probably already when you're starting to plan your parenthood.
Yeah, okay, excellent. Thank you so much for this. Okay, and there's a follow-up as well, actually. Have you seen such statistics of mothers giving birth to such problems?
No, I haven't, but it's technically possible. 1 in 19,000 means that 1 in 19,000, which is extremely rare, and I haven't seen it, but it's genetically possible. So again, Angela, I would be very confident with this remaining risk. Honestly, I would go ahead with the procedure, but then again, there's not a guarantee that this won't happen. The good thing with this situation that you have, and that those diseases are not life-threatening.
Okay, all right. Thank you for reassuring the patient indeed. And as you can see, there is a thank you from Angela as
You're
well.
welcome.
Yes, thank you. But all right, perfect. Thank you so much. At least for now, I do not see any questions. So we will be slowly finishing if you do not have any. But if you do, this is your time to use. So therefore, go ahead and type those in. If not, we will be finishing. But perhaps, Clara, is there anything you could add on the topic? Anything that
I think that you know, as this question was showing, when we start discussing numbers, it might be a bit frightening. I think it's good to have the information. I think it's good that we all know that we all can carry diseases. But the aim of these expanded carrier screening tests is precisely to assess it better and to be able to be more relaxed, to be more confident about your chances of conceiving with more or less very high percentage of having a very healthy child. So the aim of this is to try to relax us. So we have to discuss clearly the information with our patients so that they understand that if they have a risk that's, you know, lower than 1 in 500 or 1 in 1,000, they can be very confident about the procedure, and it's better to know and to be able to detect it than not knowing.
Yes, exactly. I mean, if you hear 1 in 19,000, definitely feels okay. You can see, you can clearly, I mean, you can see it more clearly, right? So it's like,
Exactly.
Okay, it's not, it doesn't sound so scary, I would
Exactly.
say. Perfect. Thank you so much. I do not see any more questions, so we will be finishing for today. But as always, I want to mention that if you would like to get in touch with Dr. Clara and, of course, her team, and would like to get some more answers, more details, you can also use this link I have just sent to you. There is an option to ask your own questions, and of course, I'm sure the team will be happy to get back to you with some more details. So thank you so much, everyone, for joining us, for listening, and for the questions, of course, as well. And Dr. Clara, it's always a pleasure to have you with us. Thank you again for very interesting presentations. You can see, thank you, Doctor. There are some thank yous for you as well. And
Thanks for being here this evening, and thank you, Caroline, again for hosting this event for us.
It is always a pleasure to host it and cooperate with you. So I just hope we will be able to do it again. And just so you know, as you can see, thank you again for giving the info, and more importantly, the comfort. Just what we mentioned. It's good to know.
Good to know, yes.
Yes, excellent. Thank you so much, everyone. And as always, I want to mention that this has been recorded, so you will still have a chance to re-watch it. You will be able to find it on our YouTube channel, but also on our website, myivfanswers.com. And as you know, there are more events coming up, so stay tuned. We will be back tomorrow at 6 p.m. and at 8 p.m. with some more topics and with some other top experts. So don't miss out your chance to also ask your questions. Thank you, Dr. Clara. Once again, thank you all. Have a lovely and relaxing evening. And till the next time. Thank you. Bye.
Bye.